Hello, everyone. I'm Leonel August Rodriguez, the Executive Vice President for Access Medical Labs. I'd like to thank everyone for joining us on another Access Live, where we bring you insight from leading medical experts. We do ask that all questions be submitted via the Q&A, as they will be answered at the end of our lecture. Today's webinar features a leading expert in hormone therapy and regenerative medicine. With a Doctor of Pharmacy degree and a research fellowship from the University of Michigan, she is also an adjunct associate professor at George Washington University and CEO of Pharmacy Solutions. She has authored numerous works on pain management, personalized medicine, and is an international speaker. Please join me in welcoming Dr. Sahar Swidan.
Lionel, thank you for having me today. Thank you, everybody, for joining us today. So for the next 45 minutes or so, I'd like to discuss hormone replacement therapy. As Lionel mentioned, I was really always in pain management arena, neurology, and then, as I went through training and clinical experience, I started to like catamenial migraines, catamenial seizures, catamenial asthma, catamenial everything. And so I'm like, oh my God, it must be these hormones are really important. And they're definitely worthy of learning a lot more than the 2 hours that we all get in our educational venues on hormones. So I always tease, I said I had to become a hormone expert, not by choice, but by force. But it's really an exciting time to actually hormones were vilified, as you guys know, for many years. And this is really an exciting time to really learn the science and how we can use this as one of the tools, to help our patients with longevity, wellness journeys, and so on. So today, what I hope to do in the next 45 minutes is to kind of review that with you and then kind of open it up for questions. So we'll look at different what is the standard of care now? What's the science say about hormones, safety, efficacy, obviously risks? What are the different methods for delivery, testing modalities? And then we'll wrap it up for questions and answers. So I don't want to belabor that point, but as you know, when the Women's Health Initiative came out in 2002, of course, when we said, oh my God, all hormones are bad, take everybody off hormones, the use of hormone obviously dramatically declined after the Women's Health Initiative trial, because I was saying, oh my God, it's causing cancer, it's causing heart disease and all that stuff. So now we have this decade, 2.5 decades of women that really were not subjected to the hormone use. And this is now what we're seeing is, you're 75, 70 to 75 to 80, even, maybe years of age women that were not subjected to hormone therapy and possibly the benefits from hormone therapy. So really, after almost 22 years, some data started to really reassess the Women's Health Initiative trials and some of the issues that maybe came out of from that and saying, are hormones really bad and should we be relooking at this? And so you see in the last 3 to 5 years, a lot of data has come out to really that have re-looked at the Women's Health Initiative trial and many other closer looks at hormones to really better assess the safety and efficacy of these. So this was looking at menopausal hormone therapy among the Women's Health Initiative randomized trial. So among postmenopausal women who participated in these trials, estrogen plus progestin or estrogen alone all cause mortality rates for the overall cohort in the pooled trials were not significantly different for the women that had hormone therapy versus placebo. So then people started going, maybe we need to relook at this, right? So where does it stand today? So then after that, we kind of started to say, well, maybe hormones are not bad. Really, let's re-dissect the Women's Health Initiative trial, but who is an appropriate candidate for hormones and when is the best time to start hormones? So then we started looking at this quote unquote timing theory, what everybody was calling, if you will. And really, most of the data started to show that really hormones seems to be, for the most part, safe and effective if they're started early in the perimenopause to early menopause stages, and definitely in women that have been less than 10 years of menopause. And the reason for that is, what is this magical 10-year cutoff? It was really the increased risk of cardiovascular disease, right? So as women, obviously, and men get older, the risk of, cancers and heart disease obviously increase. So that's what they said, this kind of window of opportunity to get the most benefit with the least risk for hormones is in this 10-year mark. And the average age for women in menopause in the United States, at least, is about 50. So they said, start it early. And then after 10 years, the risk versus benefit may not be there. And so a lot of people would use it and then go, okay, great. Well, what do we do after this 10 years if women are doing good? They're feeling great. And how do we continue to improve that? And then, oh my God, lo and behold, the study came out. I was looking at it. I almost fell out of my chair when this came out. It was the effect of hormone therapy on survival, cancer, cardiovascular, dementia risk in 7 million menopausal women over the age of 65. So obviously this looked at menopausal women that have obviously been in postmenopause for 15 to up to 40 years, because this was in the Medicare population and this was a retrospective observational trial. As soon as I saw that, being the shy person that I am, I reached out to Dr. McDonald right away and I said, oh my God, can we dissect this further with you? And I actually brought him to speak in our fellowship program. I'm the director of professional education for the American Academy of Anti-Aging and Regenerative Medicine, A4M, which I know probably some of you are fellows with us. And if not, we definitely urge you to join our fellowship because we really deep dive into, hormones, assessment, endocrinology, and dysfunctional medicine in general. So what did the 7 women trial show? And it was in women mostly, obviously, like I said, 65 years of age or older. So for the most part, they've been menopausalish for at least, like I said, 15 to 40 years. So for women post-hysterectomy, estrogen alone is good. For women with the uterus, estrogen alone without progestin, obviously for endometrial protection, if you don't use progestin, it increases the risk for endometrial cancer. And the use of progesterone also. And so in the literature, I will highlight that a little bit later. The term progestins, progesterone, and progestogens still gets mixed up all the time. So it's very important when you read clinical trials to really dissect that. And really we'll show some, and I'll show you some data later why progesterone is definitely much more preferred to use in patients for the beneficial effects as compared to the progestins or the synthetic like medroxyprogesterone acetate. So most of the data showed that the use of progesterone prevents endometrial hyperplasia, and common regimens in the literature that were, conferred endometrial protection were 200 milligrams per day for about, 12 to 14 days per cycle, or continuous, 100 milligrams per day. An alternative is daily progestin, which obviously will suppress periods, but giving the risk with estrogen and progestogen, because in the Women Health Initiative trial, actually, when they redissected the data, the risk of breast cancer was mostly seen not with estrogen, but it was when we used estrogen and mainly conjugated equine estrogens with progestins. And that's when the risk of cancer, breast cancer, was increased. So the other really interesting part, because remember we said, oh my God, after this 10 years, the risk of heart disease increases. And that's why maybe we don't want to use hormones after that. But in their analysis, actually, estrogen therapy use overall was associated with a significant 19% reduction in all-cause mortality. And obviously cardiovascular was part of that. And it was associated with a reduced risk of breast, lung, colorectal cancer, as reported by others also. They also saw an associated reduced risk of congestive heart failure, VTE, strokes, and dementia relative to no estrogen use. So Dr. McDonald, uses this kind of like Wizard of Oz he loves. So he said it was the good witch of the South. So risk reduction was significantly greater for estradiol. So remember, estradiol is bioidentical versus conjugated equine estrogens, horsey estrogens, as I call them, and vaginal and transdermal versus oral. Now we know definitely, I always, when I teach at the A4M in our modules, I always say, if you learn nothing from the lectures, please don't use oral estrogens. So definitely in this 7 million and follow-up 10 million study that we'll share with you shortly, You want to use estradiol, bioidentical. You want it transdermal or vaginal, not oral, and you want to use physiological, so low or medium doses versus high doses. Estrogen progestin therapy use was associated with increased risk of breast cancer across all types, routes, and strengths, which is, quote unquote, he called it the bad witch of the South. So 19% reduction in mortality risk in ET, and these were consistent with the other studies that were shown. So they also saw a small increased risk in ischemic heart disease with ET alone. However, this increased risk was mostly concentrated with the high and medium doses of estrogen therapy. So again, a lot of times I'll get accused of teaching quote unquote homeopathic or pixie doses of hormones. But again, you want to just mimic physiology. And this really reiterates that fact that we should use physiological doses of hormones. So in women without a uterus, estrogen monotherapy is fine. This is where I disagreed with Dr. McDonald, which we will discuss later. It reduces mortality and risks of many cancer. Monotherapy is only safe after a hysterectomy in women with a uterus, that they should take a progestin along with their estrogen. But I disagree with that also, and I'll tell you why. And they should use progesterone, 200 milligrams, 12 to 14 days per cycle, or 100 milligrams daily. So then they followed it up with this study. Basically their conclusion was, in general, risk reduction appears to be greater with low rather than medium or high doses, vaginal or transdermal preparation versus oral. Then they followed it up with this bigger study. So they followed these women and added more. So this was the 10 million women study. And basically you have the slides, and I don't want to belabor that point, but this is really what they were looking at: all-cause mortality, 5 types of cancer, 6 cardiovascular diseases, and dementia, right? Because what's the role of hormones? We're not trying to make these people fertile myrtles at 70, as I call it, but we're really trying to maintain memory, mobility, and function. So this is basically what they looked at. And again, they saw very similar results. Estrogen therapy, 19% reduction in mortality risk, decreased risks in breast cancer, lung cancer, colorectal cancer, and several cardiovascular conditions. They saw better outcomes with low rather than high doses, as they saw in the prior trial. Vaginal or transdermal was definitely safer than the oral preparations, and estradiol, bioidentical, versus conjugated equine estrogens. Combination therapy showed reduced endometrial cancer risk, reduced ovarian cancer risk, and improved cardiovascular outcomes. So this data suggests that progesterone, natural, bioidentical, generally has a more favorable safety profile than the progestins, particularly for overall mortality, breast cancer reduction risk, which has shown in many other trials, cardiovascular outcomes. However, progestin appears slightly more effective for endometrial protection when combined with estrogen. So remember, estrogen is gas on breast and endometrial tissue. Progestins and progesterone is the brakes on endometrial tissue, but honestly, progestin's very different effect on breast tissue, and it's when we mix estrogen with a progestin, the incidence of breast cancer increases. So why are people now kind of all of a sudden coming back to hormone replacement therapy, but more particularly bioidentical? And remember, so now we have a 10 million women study showing estradiol, which is bioidentical, showed better outcomes than the synthetic counterparts. So a lot of people are drawn to quote unquote natural. There's appeal now that hormones are marketed, that they're one of the pillars of longevity and wellness, and that really hormone replacement therapy seem to be improving a lot of aspects of care, right? So dementia, cardiovascular disease, and reduction in some of the breast cancers. So let's talk a little bit about terminology, right? Because everybody goes, well, I want compounded or I want natural hormones. But I think the more important thing is we really have to teach patients what is the difference between synthetic and bioidentical. So bioidentical hormones are plant derived. They usually come from soy or yam bases. versus animal derived. So conjugated equine estrogens, as you guys know, comes from pregnant mare's urine, and they kind of take the horse's pee that are pregnant and basically distill it and get the estrogens out and then process them. So obviously bioidentical for the body are better just because the body knows what to do with them. It's the lock and key concept, and they match what our body makes. And more of the trials are showing that when we use bioidentical hormones, the health effects seem to be much better and the outcomes improve. But, natural means nothing, right? So, because when people get their hormones, I always teach the patients, does it look like a yam or a soy to you? No, it does not. It undergoes a lot of chemical reactions to take that yam and the soy, distill it, clean it, modify it to get the white powder, if you will, where we make an estradiol patch or an estradiol cream, or in compounding, an estradiol cream or a bias cream, an estriol. So, very important to distinguish that, they're not necessarily natural, but absolutely we want to use bioidentical, which means it's the same chemical structure that your body makes. And synthetics obviously are synthesized in a lab, and they're not necessarily exactly, they could be a little bit similar, but they're not exactly what like your body makes. So sometimes the synthetic hormones, the key and the lock, right? The receptors, they don't bind as cleanly, if you will, and they don't confirm the same physiological effects as bioidentical hormones. So they don't meet the definition of natural, and they do not meet the definition of bioidenticals. So bioidentical, there's also a lot of misconceptions out there because people go, well, I don't want any of those, commercially available hormones because they're not bioidentical, and that's not true. And we'll go through this. There's a lot of FDA approved products that are bioidentical, and then absolutely compounded hormones, depending on the powders they use, are bioidentical. So this is where a lot of the misconceptions sometimes with providers and patients' lives. So what are the targeted receptors? So when these hormones, bind to different receptors. So estradiol, so we have estrogen receptor alpha, beta, and another one that we're not going to complicate things too much right now. But estradiol kind of binds equally to estrogen receptor alpha, proliferation gas, and estrogen receptor beta is more the brake. So the hope is estrogen receptor alpha and beta, the gas and the brakes are equal, and we just get the good effect without too much proliferation. Estrone, which is the much stronger estrogen, preferentially binds to estrogen receptor alpha, more gas, less brakes. And estriol, which is almost like an anti-estrogen, as it's called, or a modifier, is really binds to the brakes, estrogen receptor beta, a little bit more. Progesterone, bioidentical, not synthetic, binds to progesterone alpha and progesterone beta with equal strength. And then medroxyprogesterone, which is obviously the synthetic progestin, binds much stronger to these. But the physiological effects are not the same. And I'll show you that in a little bit later. Also, medroxyprogesterone binds a little bit to the adrenergic receptors and the glucocorticoid receptors and the mineralocorticoid receptors. So it tends to have a little bit of a cortisolish effect, and also, a mineralocorticoid effect. And testosterone obviously mostly binds to the androgen receptor. I'm sorry, not androgen, androgen receptor. So what are the tissue effects, right? So all of these hormones, remember, every single cell in your body uses hormones. They are chemical messengers. In the CNN, estrogen obviously helps vasomotor symptoms, cognitive improvement, mood improvement. Progesterone, very neuroprotective, very good for mood improvement. I always tease when people have a luteal phase defect, progesterone deficiency, I always tease it's probably a progesterone deficiency and not a Prozac deficiency. As you know, a lot of perimenopausal or women with PMDD, mood dysregulation around periods, things like that, they really get put on a lot of SSRIs and things like that. And a lot of times it's a progesterone deficiency. Progestins versus, progesterone, bioidentical, mood improvement, neuroprotective, memory improvement, progestins don't confer the same thing. And then testosterone is neuroprotective, cardiovascular risks, again, very cardioprotective in men and women, as even the Traverse trial showed in men now. Bone health, obviously, multiple trials showing bone health. Again, the progestin synthetic don't do that. Urinary tract, I know we have a lot of improvements, when we give women hormones and UTI, incontinence, things like that. Hematologic, right? Coagulation effect. Polycythemia if you over testosterone for sure in men and women, mammary glands, and hormone. So how are these basically naturally occurring? And then if you give it exogenously, how are they made? So estrogens are made, the body makes the 3 estrogens, right? Estradiol, estrone, and estriol, which is made in the body obviously with a conversion reaction, but mostly the estriol levels skyrocket during pregnancy, just like estrone levels dramatically increase after menopause. So they're mostly secreted by the ovary, the corpus luteum a bit, and then the placenta, obviously during pregnancy. Their biosynthesis really depends on the aromatase enzymes, which converts testosterone to estradiol and androstenedione to estrone in fat cells, liver, muscle, and the brain. There's also what we call intracrinology, where the body takes DHEA and actually inside the cell makes its own hormones, if you will. And estradiol production is obviously regulated by FSH and LH hormones. So, like I said, estriol mainly this thick uterine lining during pregnancy. Estradiol obviously has many functions, and estrone needed, but it seems to be kind of, like we have quote unquote bad cholesterol. Estrone seems to be the quote unquote bad estrogen just because it's so strong and potent. So these are the FDA approved, things for estradiol. Obviously, perimenopausal and menopausal symptom relief, vasomotor symptoms, obviously bone health and prevention of osteoporosis, hypogonadism and certain genetic disorders, right? XXY and those kind of things. And then obviously the derivatives conjugates as contraceptives. So remember, these hormones are carried throughout the body in shuttles. So only 2% of circulating estradiol is free, and the rest of it basically hitches a ride on the albumin, or about 40% on sex hormone binding globulin, which also binds testosterone. So sex hormone binding globulin basically shuttles the estrogen and testosterone in the body, and then about 60% is bound to albumin. So think about your patients that are cachectic or malnourished, that are, hypoalbuminuria, with liver diseases. They're going to have more free hormones, and therefore they may have a stronger effect. Also, if the sex hormone binding globulin is not well balanced, again, it's the shuttle that carries this stuff. So estrogen and testosterone kind of compete for that shuttle. So these are the things in the nuances you want to look in each patient to see if you're getting like, oh, I don't feel good. These hormones are not helping. You want to look at these other things to see, is there something going on? Also, remember, these hormones, you can't just slap them and wish for the best. They have to be converted to glucuronides, sulfates, methylated out of the body. So again, if the patient has a clogged gut, because all these hormones undergo intrahepatic recirculation in the bile and reabsorbed in the bloodstream. If that system in the gut is not a healthy gut, phase 1 and phase 2 detox in the liver, if that system is clogged, again, they're not gonna really metabolize these hormones well. And sometimes they can build up on patients and go, God, these don't make me feel good. What's going on? So these are important things to look at when you're hearing from their patients. And also you have to make sure their body is ready to receive hormones. So obviously we know, with estrogen, people will make, obviously you'll start making estradiol levels slowly in the, early follicular, they peak at ovulation, and then they carry through the luteal phase with estrogen. With progesterone, as you go, they may a little bit in the follicular phase, and obviously you get the luteal launch really later after the corpus luteum release. So on average, the average female secretes about 36 micrograms per day of estradiol in the follicular phase, about 380 mics before ovulation, and about 250 micrograms during the midluteal phase. Obviously, these things decrease. Now, men also make estradiol, but obviously not as much as women. And the average male secretes about 50 micrograms of estradiol per day. So these are very lipid loving, very lipophilic. So they kind of go everywhere and they crosses, all cell membranes, and they bind to these estrogen receptors, as I showed you. Estradiol is 10 times as potent as estrone and 100 times as potent as estriol. Remember, estriol is the weak estrogen. So what are the different formulations that are out there? Obviously, we have patches, right? Which these are bioidentical. So 17 beta estradiol. So most patches, but not all on the market, are bioidentical. So depending on where you apply them, they can have different bioavailability. Why am I telling you this? Because sometimes patients will go, oh, well, I did great, and now I don't feel as good. Well, it could be where they applied it now because you want to rotate application sites, but also there's a lot of generics out there. So you have to make sure, yes, all generic drugs or patches, in this case, estrogen patches, have to contain estradiol, for example, but the release and patch mechanisms could be very different. And also the patch sizes, right? Like, the Miniville, the Vivelle Dot versus Vivelle. Estraderm, they're different sizes. So sometimes the release mechanisms may be different for one patient to another, and they may do better. A patient may do better with one kind or generic versus another. Also, the patch technologies, matrix versus reservoir. If it's a matrix patch, because we get this question a lot, can I cut my patch? If it's a matrix patch, you can, but if it's a reservoir patch, you cannot, because then that releases all the drug all at once if it's a reservoir patch, and you don't want to do that. So transdermal bioavailability obviously is way higher than oral, because when you give it orally, it undergoes a lot of first pass metabolism to all these different metabolites. And then patches have different, diffusion, right? If it's a twice weekly patch versus 1 weekly patch. Even when I flip patches, I always like to keep the old one on for about 12 hours to really kind of minimize the ups and downs of patches even. And like I said, make sure if it's a reservoir patch, patients do not cut it. Estradiol obviously has roughly a half-life of 6 to 8 hours. But the patch, because it's a continuous release, it really doesn't matter in the sense they're not going to get those peaks and valleys as they would, let's say, if they're taking an oral pill, or sometimes the creams or gels, obviously, where sometimes we may have to administer them twice daily because of that. Also pay attention to the patient population. Overweight or obese individuals, they may have poor bioavailability because they get, more adipose tissue, usually has less blood flow. So therefore there might be, less systemic distribution. Athletes may have more blood circulation, obviously, because of the heat. Also, if people have fever or they're sweating, they will release drug faster out of the patch or hormone in this setting. Anorexia patients will have poor absorption, less fat, reduced volume of distribution, so they may have more fluctuation. And then heat exposure, like I mentioned, definitely can, increase or decrease the patch. There's also topical gels on the market. Again, these are bioidentical, 17 beta estradiol, Divigel, Elestrin, Estrogel. So these are bioidentical estradiol, commercially available creams and gels. So again, they tend to have less first pass because they really go to the body and lymphatics first, and the liver second, versus oral, again, like I said, if you learn nothing else today, please don't use any oral estrogens for the multiple reasons that with increasing, obviously, biliary stones, with increasing coagulation risk, decreasing growth hormone levels, and all that good stuff. So we don't want to use, obviously, the good old stuff that we all learned in school, estradiol, the conjugated equine estrogen, and then many others. Then we have vaginal rings. So estring is bioidentical, 17-beta estradiol. Femring is estradiol acetate, again, synthetic. Progesterone, mostly made by the corpus luteum. Again, 2% is only free and 80% is bound to albumin, and 18% bound to corticosteroid binding globulin. So this is the same shuttle that carries the cortisol. This is why people, when they go on vacations, I always tease, they get pregnant, right? They're not as stressed. The cortisol is not fighting for the shuttling, if you will. And then progesterone has a very short half-life, and it's converted in the liver to pregnitadiol, pregnitotriols, which are conjugated and excreted in the urine. Men also make progesterone. Women, on average, tend to make about 20 to 25 milligrams per day endogenously in the luteal phase. In the luteal launch. So again, you'll see the highest levels of progesterone, obviously, in the luteal launch. And if women have a good launch, you'll clock a level of 18 to 20 or higher nanograms per milliliter of progesterone. Progesterone, very lipophilic. It's an allostatic activator of the GABA receptors in the brain. That's why progesterone is very neuroprotective and very calming. And very good for sleep, like insomnia, especially obviously if it's caused by hormonal type issue, because it hits the GABA calm receptors in the brain. Now, progestogens is the class that underneath it holds the synthetic progestins and natural micronized progesterone. That's why the literature is so confusing. So if you see a study and you're reading it and it says a progestogen was used, you really don't know if it was synthetic progestin or the natural micronized progesterone. So progestogens contain the synthetic forms of progesterone, and these are all the different subclasses of progestins, like the 17-hydroxyprogesterone group, the medroxyprogesterone acetate, and all these different ones that you see really birth control pills, right? But and these are basically the different classes. Then you have the spironolactone derivative, the drospirenone, which tend to have an anti-androgen effect in addition to being a synthetic progestin. But like I said, most of the data has shown for protection of brain, health, bones, breast, you want to use progesterone, natural micronized progesterone, and not progestins. Oops, sorry. So Provera is the old stuff, don't use. Now, sometimes, for like shedding DUB, short term, we may need to use it, but really for long term, it doesn't have the same physiological effect on brain, bone, breast tissue. Progesterone and medroxyprogesterone, very good for shedding the uterine lining, but doesn't confirm the same protective effects. You really want to stick to progesterone. The half-life of progesterone is very short. That's why sometimes you'll give people progesterone, they sleep great, and about 3 in the morning, bing, their eyes are open. So sometimes having the pharmacy compound a longer lasting progesterone for you may help keep patients asleep better. So this is really for you, progesterone versus progestins, and why their physiological functions are very different. Progesterone is anti-androgenic, hair growth, hair loss with progestins, increased bone mineral density, decreased bone mineral density, cardioprotective. Some studies showed possible increase, especially with artery spasms, neuroprotective, potential for cognitive decline. So again, like I said, most of the literature says use natural micronized progesterone. Obviously, progesterone works everywhere. It's not just for uterine protection. This is what I argued with, NIH study that really progesterone has the neuroprotective in addition to the uterine effect, the brain effect, the bone effect. Transdermal progesterone, right? We have some data out there. Transdermal progesterone increased serum progesterone to a small extent, but the achieved serum levels of progesterone were lower than those achieved with vaginal or oral, and therefore was insufficient to protect the endometrium. So this is why the recommendations for endometrial protection with progesterone is for oral or vaginal. The studies that have shown endometrial protection were oral progesterone 200 milligrams for 10 to 12 days per month cycle, or 100 milligrams daily, or 45 to 90 milligrams intravaginally. So very important now, not to use transdermal solely for endometrial protection. Pregnenolone, another important hormone, especially for memory, you can check that and replace it. Usually you can start 5 to 10 milligrams and titrate slowly to achieve a blood level of 100, which is, optimal, or the middle range of that lab. DHEAS, another blood level that you can get, or in urine and salivary, very important for immune modulation. Too, is another hormone you want to check. For women, the average women replacement dose, if they're low, the average female makes about 2.5 to 5 milligrams per day. So for physiological replacement, the average female will need about 2.5 to 5 milligrams of DHEA. Men definitely need more, so usually 25 to 50 milligrams per day. There is a commercially available product on the market called Prasetone, Praseterone. This is an intravaginal formulation of DHEA. And it's 6.5 milligrams of DHEA and about 1.3 ml of white pulp base. They did see elevation because, remember, the body takes DHEA and can convert it to testosterone and estrogens. So they did see an increase in serum levels of testosterone and estradiol post replacement of DHEA intravaginally. So what you stick in the vagina, again, doesn't always stay there. In whatever you stick intrauterine, like the Mirena, the progestin doesn't just stay in the uterus, right? So I put for you really why the physiological doses of replacement. This is really what the average female secretes of the different hormones in different phases. I think we've hit the point home. Don't use oral versus transdermal, and why, for the reasons I mentioned earlier. Definitely much more protective and safer to use transdermal or vaginal versus oral. So this is really the dose summaries in a lot of the clinical trials. You don't want to use oral. Most clinical trials have shown that estrogen or estradiol, you want to use bioidentical, and you want to use the patch or transdermal. So the patch really looking at 0.025 to 0.05 milligram patch. It has been shown to confer endometrial protection, probably cardiovascular protection. And then if you're going to use gels or creams of estradiol, is to have an estradiol dose of 0.5 to 0.75 milligrams transdermally. If you're using compounded, again, you want that estradiol level to be delivered at least at 0.5 to 0.75 milligrams daily for the estradiol portion. And if you're using a bias like compounded, you can have it with estriol. Testosterone, again, women make very little testosterone per day. 150 to 300 micrograms transdermally has been shown to help benefit libido, mood, definitely bone health, brain health. Progesterone, we've mentioned those doses several times. And again, the DHEA, really the average female is 2.5 to 5 milligram. What you'll find in the literature, in my opinion, is a lot to start with at this dose for women. And they tend to get like hirsutism, oily skin, and then they don't like you too well. So I always like to start low and go slow, just like with any drug, same with hormones. But this is the protective doses that have been shown in the literature. And remember, you don't want to overdose hormones, because what we saw in the Women Health Initiative trial, most beneficial doses were transdermal or vaginal, bioidentical, and low estradiol doses. And in here, really, I gave you some conversion guidelines if you're going really from sublingual to oral, how you would convert it topical to sublingual to oral ratio. So if you have, 5 milligram estradiol, which you would never do, it would go roughly to 2.5 milligrams sublingual and, basically to 1 milligram topical estradiol. So vaginal administration, I just want to make that home again. If you look at the plasma levels of progesterone after vaginal oral administration, we see, because oral has a short half-life, remember, it really peaks quickly and comes down. That's why sometimes you'll go get a blood level of progesterone the next day and you go, oh my God, it's less than 1 or non-detectable. Well, this is why, because by the time you go to the lab the next day, it has a short half-life, it's gone, but that doesn't mean it's not conferring the protective effect. And you see, what you stick in the vaginal vault will get into the serum, and actually much better, because the vagina is really like a mucosal surface. And also now with the technologies, you always want to make sure the lab is using not the old radioimmunoassays, that they're using the LCM mass, liquid chromatography mass spectroscopy, because they're much better at measuring less noise, meaning measuring the parent hormone, and less of the noise of all the metabolites. And also they're much better at measuring low levels of hormones. And remember, the body makes, like we mentioned, estradiol, estriol, and estrone. So if you are ordering compounded estrogens, like a Biest in the industry, will always be 80% estriol and 20% estradiol. What we recommend most commonly now, because of the literature showing that we really probably need a little bit more estradiol than what we used to recommend, is I always recommend, if you're using Biest now, to use a 50-50 ratio, meaning you have the same amount of estradiol and estriol. And in here, I gave you some recommended dosing guidelines, really for a variety of different things for the compounded, portion, perimenopause, and then how to write them. Just to kind of give you an example, because a lot of times, like, oh, how do I write compounded prescriptions? And then for menopause. Estriol vaginally is great for healing local mucosa, so I love that for local effect. And you can also sometimes add testosterone, or DHEA is also great for local action of vaginal atrophy and things like that. Men and testosterone, just like everything, obviously, as we all get older, everything tends to decline, especially with hormonal type stuff. So testosterone replacement in men, sometimes they will use pellet. I never recommend pellets at the first hello. You always want to use injectable or transdermal testosterone in men or women until you know really how their body utilizes it, how do they metabolize it, what's the correct dose for them. Because the problem is, once you stick these pellets in, you can't get them out for 3-4 months, and their effect will be in there. So you don't want to be stuck with issues, or that they're over aromatizing to estrogen, because that increases obviously thrombotic risks and things like that. So in here, again, just due to time constraints, because usually we do 24 hours of hormone education in our module, just trying to give you a little bit of kind of the highlights of each. So here I kind of just gave you, what are the different dosing formats for testosterone in men, and some of the recommended starting dose. I always like injectable, actually, to give men twice weekly. So the average male makes 5 to 10 milligrams of testosterone per day. So the average male needs about 70 milligrams of testosterone per week. But I like to split it in twice weekly injections, because they don't seem to get the high peaks and then over aromatize to estrogens. So how do we test these methods, and what do the major organizations like NAMS and ACOG say? So actually, they say we don't need to measure hormones. Just kind of go on symptomatology, and I find that just a little bit odd because I always say, would we ever give thyroid levels without testing? Would you give insulin without measuring glucose levels? So why do we give hormones without measuring? Because a lot of times we get fooled because a patient will come in and go, oh my God, I'm hot flashing. And everybody else thinks, oh my God, the estrogen must be low. But really, hot flashes are due to too much estrogen in relationship to progesterone, adrenal issues, or low estrogen. So it's not always what we think it is. So I believe you should test for hormones because you want to use it for guidance of therapy. How do we test hormones? So you can do it in serum, saliva, or urine. Um, and there's no perfect test right now, literally on the market, that gives you the answers for all of them. So I'm just going to give you the pros and cons of each one because really there's a place and a time for each testing modality. So serum testing, really, that's the gold standard in the literature. So when they tell you, how do you measure this? It's well-established reference ranges. And what's nice about serum is we can measure other things, right? Thyroid, pregnenolone, DHEAS, sex hormone binding globulin, a comp, CBC with DIF, a PSA if you need it. Obviously, like before starting testosterone, you want to make sure there's no polycythemia, PSA issue. So we can get like a lot of more of our quote unquote regular labs with it. But, requires a blood draw. And remember, serum tests both free and protein bound hormones. So you're not necessarily just getting the free fraction, which is really what's available for use by the tissue. Serum testing, the other problem with is, remember, hormones fluctuate throughout the day and from day to day, especially in women. So when we get a serum measurement, it's only capturing that one point in time. The other problem with serum is for transdermal delivery of hormones, it probably underestimates topical hormone levels. And therefore, if you're measuring serum, you're probably going to overdose because it's going to show lower levels than what's available in tissue. And obviously, when you're poking a needle in somebody, if you're checking a cortisol or stress hormone, that may affect that level. Now, saliva testing, what's nice about it, it's a non-invasive, collection. They can do it at home, right? It measures free or bioavailable hormone level, probably closer to tissue level assessment. And it's really, even in allopathic medicine, it's the gold standard for measuring cortisol. And what's nice about salivary is you'll see the 4-point cortisol curve, right? Because it's really important to know what is that cortisol curve doing, because that really tells you what's going on as versus, Addison's, Cushingoids, or any of the spectrums in between. And, we can see the DHEA level. Now, what are the limitations for salivary? You don't want to use salivary testing if the patient is using trophy or buccal hormone delivery, because obviously you're going to get psychotically high levels. You got collection restrictions, right? If they're eating, drinking, brushing teeth. A lot of times too, if people are rubbing the hormones transdermally with their fingers or hand, and they keep touching their mouth, you'll get exaggerated levels also. There is not really correlation with serum. More of a tissue level assessment, which sometimes is important because obviously, where do hormones live? They live in tissue, not in the bloodstream. And it's definitely a better assessment of peripheral tissue conversion of hormones. Because remember, fat cells, liver, and other tissue convert hormones. Urinary test, what's really nice about it, and I always say, even if you're testing hormones with blood or saliva, you have to do urinary hormones at some point, because it's very important to know when you give hormone replacement that you assess the metabolites and make sure you're keeping them into the proper pathways. And what's nice about urine also is you get a pattern assessment because you're collecting a 24-hour of hormone production, or obviously how you're replacing it. Some studies now are beginning to show correlation with serum levels, especially for estradiol and testosterone. And obviously, if you're administering hormones vaginally, again, because you're going to pee hormones out too, that you may get an overestimate really of hormones. And what's nice about the urinary, again, if you're using serum or saliva, is you have to look at the metabolites and make sure, again, we're keeping the estrogen metabolites in the healthy pathways and not taking them into this 4-hydroxyasterone, which really causes a lot of DNA damage and problems. Now, I already mentioned this, mass spectroscopy is becoming the preferred method for hormone testing. It definitely has higher sensitivity and specificity. We can have the ability to measure multiple hormones simultaneously. It's better standardization across labs because, now you'll go to one lab and one uses radioimmunity, one uses that. And then it also reduces interference from other compounds. Remember, like it really measures the parent compounds a bit better. So these are, like what do you test before starting hormones in men and women? So for men, you always want to get like a total and free testosterone, a sex hormone binding globulin, a dihydrotestosterone, DHEA sulfate, because that's the storage form, and estradiol, important to check in men, LH and FSH, because you want to see, is this high, primary or secondary hypogonadism, prolactin, to make sure their issues are not due to pituitary adenoma or anything like that. And sometimes, also you want to get a CBC to make sure you don't have already hemoglobin issues. You want to get a PSA to make sure there's nothing really in the prostate that's going on before starting hormone therapy. And very similar pattern also for women, depending, again, salivary testing, urinary testing. I gave you the pros and cons. What's nice about salivary too, if you have people with irregular menses, they're still menstruating, or fertility issues, you can do a 28-day cycle mapping and see really what's going on in their cycle, and then you can better pick up some things that are happening with them. For men too, when do you collect, blood samples, right? You want to collect early in the morning to compensate for the natural diurnal variation of testosterone levels. So remember, men literally have 4 distinct different peaks of testosterone per day. So for men 45 and older, probably maybe not necessary. So definitely, you want to have it as early in the morning. And, you don't want them after they run a marathon or exercise, because that affects levels also. So this is really, there's definitely all these different modalities. So I worked with Access Lab to give you, a comprehensive female panel and a comprehensive male panel. And this is at reduced cost for you guys. This is, you really want to look, this is like a wellness panel, as I call it. For females, you want to look at comp, because you want to make sure there is nothing issues, that are electrolytes or methylation. Liver is healthy because you're going to be detoxifying these hormones. A CBC with DIP, again, you want to make sure they're not polycythemic before we give them testosterone, men or women. Lipid panels, we know hormones in general affect lipids in a good way. Thyroid panel, free and total. Sex hormone binding globulin, sometimes we don't need to give them testosterone or hormones or estrogen, even if the sex hormone binding globulin is not properly managed. And look at metabolic issues when you see sex hormone issues. Obviously, the estrogen, the 3 estrogens, the dihydrotestosterone, especially in women that complain of PCOS type symptoms, hirsutism, things like that. FSH and LH to kind of verify where they are in their menopausal journey, if you will. The DHEAS that we discussed, CRP. I always love looking at inflammatory markers, because again, you want to look at the general wellness. Hormones are one avenue of that. Optimize their vitamin D. Look 4-point cortisol, salivary. I love. Obviously, this goes with the IGF growth factor, hemoglobin A1C, because it's very important. I can tell you, you can give them all the hormones, and if they have a lot of sugar issues, unstable sugar levels, you're not going to fix their hot flashes the best. Thyroid antibodies and things like that. And very similar, panel for men with the addition of the PSA, obviously. So this is, the panel that I recommend. And definitely, you want to use serum. And remember the pros and cons of that, saliva, the pros and cons of that, and urine, definitely the pros and cons of that. And make sure if you're using serum or saliva that you do check urine at some point. Once a year, I always recommend minimally because you want to make sure the hormones are staying in the right pathways, and then you can modify that journey. So what are the takeaways? You want to replace hormones, measure and make sure they need hormones first, and you want to replace them in physiological doses, transdermally, and at the lowest effective dose. You don't want to use estrogen orally. You want to give progesterone with or without a uterus because it's very important for many other functions in the body. You want to monitor and adjust therapy accordingly, and definitely properly consent patients. I think now, fortunately, we have a lot more benefit, and definitely any treatment carries some risk. So it's important to consent patients on the risks and benefits of hormone therapy per patient. And thank you for your attention. I know I threw a lot at you and you're drinking from a fire hose, but there is so much information. But definitely join us at A4M and the many modules that we hold on hormones, because I've been doing this for 27 years, and you learn something new every day, especially now. The hormone knowledge is literally morphing at warp speed. So with that, Lionel, I know, sorry, maybe we didn't leave as much time for Q&A, but I'd love to answer some questions.
Absolutely, Dr. Swidan. Amazing, amazing lecture on demystifying HRT dosage. I truly love how you started the lecture. You said, HRT was a challenge for many, many years. And look how far it has truly come. It's becoming truly mainstream at this point, right? Which is amazing, amazing to see. So let's start with some of the questions from the Q&A. First question comes up. What are the main scientific claims supporting the efficacy of BHRT over synthetic options?
Yeah, so actually, even when they redissected the Women Health Initiative trial, even the conjugated equine estrogen, because, this is how the trials came out, right? Oh my God, it's causing breast cancer, right? So actually, when they looked even at the conjugated equine estrogen, which is not the preferred estrogen, really, they did not see a huge increase in breast cancer. When they saw the increase in breast cancer, it was when they combined conjugated equine estrogen versus with a progestin. I'm sorry, not versus. Now, more of the data, like I said, and the 10 million. So more of the recent data showed that when we use estradiol transdermally with progesterone, so mostly bioidentical, the risk of breast cancer actually is nullified, and in some clinical trials showed reduction. Now, the 10 million NIH trial, as I call it, that I just presented, again, showed that we see better efficacy or less risk, let's call it, more benefit, less risk, even reduction in some of the cancers that I mentioned earlier in the study with estradiol bioidentical with progesterone bioidentical. So more and more of the data is leaning now towards, and if you look in many other studies, I can definitely bore you and put you to sleep with. Definitely there's a lot more data now to show bioidentical like estradiol with progesterone seems to be more protective. And the only exception is showed, but possibly endometrial protection, maybe slightly better with a progestin. But again, we lose all the other beneficial effects of progesterone.
Beautiful and very well said. And you will not put us to sleep or bore us at all. So the next question is, what does the literature say about the use of injectable estradiol and how it should be dosed?
Yeah, that's an interesting question. So I always said, God, do you guys know what we use injectable estrogen for? Well, usually to stop bleeding, right? They used to give conjugated equine estrogen or Premarin injections when we wanted to stop bleeding. Not a good way to do that. Really, that has lost a lot of favor. So we do have kind of a conjugated, like the testosterone cypionate enanthate, right? We have an estrogen longer term. Again, it's synthetic. It's not bioidentical per se. You do cleave, the chemical part of it, and then, estradiol is released. But really, there is not much data that has looked at that. And really, in the old days, they used to do that. There's some benefits because they're like, oh, I don't have to worry about injecting it every day, kind of like the testosterone cypionate. But really, a lot of the studies have not looked at it. The recent data has mostly been with transdermal and vaginal estrogens and not really injectable.
Excellent. And what considerations, and I believe you mentioned this already, if you could repeat, what considerations should be made when selecting between the different methods, such as oral, transdermal, vaginal, and for the HRT therapies?
Yeah, so oral never, as I tease, just because of the negative effect. I
Yes.
don't like troches or buccal administration of estrogens mainly. Yes, some will be sublingual absorption, but you will still swallow some, and that will still cause, the issues with the oral, as kind of we know about. Again, most of the data really is showing transdermal. And then vaginal, vaginal is not the best, easiest route. So that's why I think the majority, even clinicians and patients, tend to lean more transdermal, patches, a bias cream, like if it's compounded, or the FDA approved bioidentical, creams and gels that are on the market, and the mist, there's a mist also.
Perfect. And can you elaborate a bit more as to why never oral?
Well, so we think, like I mentioned, definitely we know this from, the oral contraceptive data, from the oral estrogen data. Always due diligence and warning to the patient is it can increase clotting risk. So the biggest thing is it's clotting risk. They've been shown to increase gallstones and biliary type disorders. They decrease growth hormone levels. So those are the biggest, but it definitely in lipids. So depending, really even transdermal can take lipids different ways. That's why you want to monitor lipids when we're, doing hormone therapy, to make sure we're keeping everything in the correct lanes per se. But that's the biggest concern is really the thrombotic risk of oral estrogens.
Excellent. And what's your opinion on estrogen blockers for individuals who are on TRT?
Yeah, so absolutely. So like I mentioned, men make estradiol and estrone and estriol. If you overdose testosterone, because the body goes, whoa, too much, I don't need as much, then they tend to convert too much to estradiol and DHT, dihydrotestosterone. So absolutely, we need estradiol levels in certain range for men. Sometimes the negative out there is some clinicians feel like they have to drive the estrogen to zero in men, which men need estrogen for brain health, bone health, cardiovascular protection, just like testosterone. So absolutely, if they're over converting and over producing estrogens, you want to control that. Now, we don't always have to run to the aromatase blockers. We can definitely use some herbals, some, really kind of unclog aisles 2, 4, and 6, as I said, like these estrogen metabolic pathways. We definitely gut rehab, make sure the microbiome is healthy, probiotics, fiber is amazing at reducing estrogen burden in men and women. So the average male and female should get at least 35 grams of fiber per day, whether you're on hormones or not. Remember, all hormones, bioidentical or synthetic, also reduce B vitamin levels. They cause a drug-induced nutrient depletion. And B vitamins are critical for phase 2 detox. So all men and women on hormone therapy, synthetic or bioidentical, need to be on a multi-B complex. So that will help with phase 2 detox. You can use glutathione, sulforaphane to also unclog those pathways, and that can lower estrogen levels. And then if we need phase 1 detox, which is your estrodem, for example, like indole-3 carbinol and diindole methane. But you always go backwards with detox. You always unclog phase 3, gut. then phase 2, B vitamins, magnesium, sulforaphane, glutathione, and then phase 1. A lot of people make the mistake of slapping DIM or, indole-3 carbinol or I3C or whatever first, and then they start getting phase 1 going, but then phase 2 is clogged and they actually make more intermediaries that are bad. That's why you have to go backwards. So now you can do the backwards, and hopefully that will help with estrogen metabolism, keeping them in the correct pathways and lowering the levels. If not, then you can use the aromatase blockers, for example, like anastrozole. Men need very little, like 0.25 to 0.5 once weekly for most men. They don't need a lot of this stuff. Again, you want to keep estradiol and estrone and estriol in men in the middle of the range. Not too high, but not too low either.
What's beautiful about your answer, you answered about 6 questions rather, that I was getting ready to ask you. So I appreciate the response there. I have a case inquiry. Okay, so we have a 52-year-old woman, post-hysterectomy, menopause. These are her symptoms. She comes from a family of strong history of cardiovascular disease. How would you approach her treatment? Her labs have shown low hormone levels for FSH, LH, estriol, estradiol, estrone, testosterone, and pregnenolone. Labs show low hormones. And would you treat the E2 and progesterone, transdermal or oral progesterone, just the E2 or the testosterone first due to low T and aromatization? It was a long-winded question. I hope you got it all.
Okay, so basically the crux of this case is I have a postmenopausal woman, showing low hormones across the board, if you will. She's post-hysterectomy, so I don't have a uterus theoretically to protect, and increased family history of cardiovascular disease. I'm assuming early cardiovascular disease, which obviously brings up a different point that if it's early heart disease versus later, it's just as bad. But my point is obviously that then you want to be more aggressive in controlling it if there's an early family history of heart disease. So what did the data show? So let's go with that. So first of all, you want to assess her personal risks. Look at insulin, look at sugar levels, look at triglycerides, look at lipid and lipid fractionation, right? You can get an expanded lipid profile because now more and more of the data is showing, even high HDL, when we used to go, oh, hooray, high HDL is protective. Well, now we know the small cracky HDL is just as bad as the little small cracky LDL, and it clogs the arteries just as bad, if you will. So definitely you want to do personal risk assessment in this person. So, get an expanded lipid profile, look at sugars, look at diet, inflammatory markers. You want to control those destinies and modulate them and optimize them as much as possible first. I think all women should get, and men, 45 to 50 years of age, should get a baseline coronary calcium score or a CTA with Clearly, because then we want to have a baseline, especially in somebody like this, which genetically that it increased risk of heart disease, but I don't know what her epigenetics are, right? So we can see the expression with her lipids, sugars, inflammatory markers, which will increase obviously her risk. Now, hormones have been shown to be protective. So actually even cardiovascular, you saw the $10 million study, if you will. I can't believe the dollar study, but it's the number study. The point is really, we've seen a 20% reduction in all-cause mortality in these women. In older women, which the risk is higher, including obviously reduction in cardiovascular disease, about 5% is what they saw. But again, I care about that person N of 1 in front of me. So I would get a calcium coronary score on this woman, expanded lipid profile, sugars, inflammatory markers, modify that destiny first. Then absolutely, she would be candidate for hormones. I would absolutely not just use estrogen because progesterone is so heart protective, neuroprotective, bone protective. Progesterone has been shown in studies in vitro to actually decrease vascular spasms and cause relaxation. So absolutely, I would do estradiol transdermally, not oral, because again, the risk of thrombosis is higher with oral. Never that in somebody like her. The lowest effective dose, transdermal estrogen, oral micronized progesterone, and then absolutely, I would replace pregnenolone and DHEA, because we know also DHEA is immunomodulatory. Or you can give her stress reduction techniques, use herbal supplements like adaptogenic herbs, calming herbs, to see if we can modify that journey also. Decreasing inflammation with an anti-inflammatory diet will help somebody in that case, because regardless of hormones or not, this is a woman that you want to control the destiny, because she is at a higher risk for cardiovascular disease. And this is what's important also, is everybody always focuses on breast cancer in women. The number one killer of women is heart disease, not breast cancer. And even in the cancers, it's lung cancer, not breast cancer. So we really need to shift that thinking. And let's not even start, we could do 24 hours like we usually do in our modules, fractures and fracture risk, without estrogens and things like that too. But okay. So hopefully that answered that question, I think, hopefully.
Absolutely. And Dr. Swidan, the audience wants more of you. So when is your next live speaking engagement?
Well, I was born to gap, as I was telling Lionel earlier, so, and now you can see why. So definitely, I'm the director of professional education and development at A4M. So I lecture in GAB at literally every module and a lot of the other educational things. I urge you all, if you want to learn a lot more about this, is to join us. We actually have our BHRT symposia that's coming up in Texas in March. So you can go to the A4M website, American Academy of Anti-Aging and Regenerative Medicine. And then we have our module 1 in our spring congress, which is in Palm Beach, right next door to you, in April. We will be offering our 2 big hormone education one, where we dive literally 24 hours plus into all this. So, it's a lot, I know, that came at you, but it's just so much information now. And it's so critical. We urge all of you guys to become menopause experts, if you will, because really this is the time for us to reverse, in the last 25 years, where we have a huge multi-generation of women that really did not get the benefit of hormones, unfortunately. And now we're hoping to kind of reverse that, with appropriate selection, right? Hormones are not for everybody, but that's again where we dive. Who's an appropriate candidate? What are the risks? How do you properly consent patients and all that good stuff? And then I'm always gabbing somewhere with a lot of, companies like Access and stuff, again, trying to teach all this good stuff. So love teaching. So hopefully you can join us at any of those. So yeah, I don't know if there's any other questions or.
With that, Dr. Swidan, love what you do. I can't wait to see you in person in April. On behalf of myself and Access, we again love to thank you for another amazing webinar on demystifying HRT dosage. To our audience, thank you for tuning in to another Access Live, where we bring you insight from leading medical experts. Don't forget to like, don't forget to subscribe, and stay healthy. Till next time, everyone.
Thank you. Thank you for having me again. Take care.